Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today I have another very important and very special guest. If there's one thing that makes sometimes myself and definitely my trainees anxious is a child with a rash. Very often they come to the ER and the resident is all anxious. Dr. Ivan, I saw this patient with a rash. I have no idea what this rash is. I really need your help. I always try to explain to the residents that the approach to the child with a rash should not be very different than the approach to the child with abdominal pain. Look for the red flags. If you find none, send the kid home to see a specialist. Our pediatric dermatologist specialist, Tace Rico, is always very helpful, very willing to help, and consulting her is often a very good learning experience. So today we're going to speak to Tace and learn a little bit about pediatric dermatology from the emergency medicine standpoint. Welcome, Tace, to the show. Thank you very, very much for coming. I know you are a busy physician and I appreciate your time. Let me just introduce you to the listeners. Tace was born in Germany, however, spent her childhood all over the place because her father was in the military. She went to medical school in the University of Miami, followed by residency in dermatology at the University of Miami. And for the last 11 years, she has dedicated her practice to the practice of pediatric dermatology. She exclusively sees kids up to 18 years of age. Is that true, Tace?
Up to 21.
21. Perfect. So I consult Tace every once in a while because we see a lot of pediatric patients with a rash. Many times I have no idea what the rash is. Sometimes it looks concerning. So I get in touch with her, and Tace is always super responsive, super helpful. My colleagues and I love having her. Welcome to the show, Tace. How are you?
Thank you. I'm great. So happy to be here.
Thank you. Thank you very much for coming. And Tace, my first question to you, it's the question I ask all my guests, is what is your ideal pediatric emergency medicine physician? In other words, we call you, we consult you sometimes in non-conventional hours. And what is your ideal PEM doctor who consults you? Someone who does a good physical exam or takes a great history or gives you a good differential? What would be your ideal person to consult you?
Of course, there's a lot of different things that I kind of wish for my EM consults to include. I mean, the big thing is that you guys are really good at knowing what is a true emergency and what is not. And for the majority of patients, that's all I really need to know. Is this something that can be seen in my clinic within the next week or two? Is it a patient that just has had bad access to care and that really just needs good follow-up with me? And I feel like that's the majority of the consults I get, because I think as emergency medicine physicians, you all are really good at picking up what is a true emergency and what really needs to just be admitted. And for the most part, I'm just kind of here to say, yes, that sounds like it is something that needs to be admitted, or it sounds like something that needs to be seen in my practice. We have very few true dermatology or dermatologic emergencies. And so those are the ones that we don't want to miss. So giving me, some good, brief history probably, but a good physical exam of what the lesions look like and really what the concerning lesions look like. And then what your differential is, because the most part is that when I look at a differential, especially from a patient in the emergency room, what we're just trying to figure out is what can't we miss? And if it's in our differential, then we need to either admit for that issue or treat that issue. And those are the big things that I'm really looking for.
All right. Is it so? What I hear you saying, Tace, is that maybe the physical exam describing the rash and whatnot would be like the most contributing factor to your decision making. Is that right?
Physical plus that differential. If there are a couple concerning lesions, like bullous lesions or something that we're always kind of looking for, but obviously the bullae of erythema multiforme is going to be a little bit more concerning than bullae of staph and impetigo or something of that nature. And so sometimes the physical does help, but sometimes it's also that differential as well.
All right. Very good. So that's certainly something helpful for our listeners to know about. The other question I wanted to ask you, Tacy, is as a pediatric emergency physician, I certainly deal with some dermatological presentations, but I have the benefit of not having to know exactly what the rash is or what the abdominal pain is from. I'm in the business of, like you said, ruling out emergencies. I don't think of myself as a diagnostician. So when I see a rash, I need to make sure it's not secondary to something serious or life threatening. Over the years, I learned to approach it from an emergency medicine standpoint. In other words, just like when I see a child with abdominal pain, if it's right lower quadrant, I'm worried. If the patient has peritoneal signs, I'm worried. I don't necessarily know what the surgical abdomen is secondary to, but I have a list in my head of red flags that make me worry, work up the patient, maybe consult, maybe admit. I always look to find those red flags. So again, for pediatric rashes, over the years, I came up with what worries me, what are the red flags that I think about in a pediatric rash. And for me that list for me is the following. So if the child is ill appearing, really that's kind of easy. Whatever the rash is, I'm a little worried. Any rash that doesn't blanch, in other words, petechia or purpura, makes me a little worried. If the rash is vesicular, same thing. If there is positive Nikolsky sign, which I don't think I've ever seen, but that would be pretty impressive. And if the rash involves the mucous membranes, if the rash is tender when I touch it on palpation, and if it involves the palms and the sole. Now, I always tell the residents, if you see some petechiae on the face and the child is coughing a lot, I can live with that. In other words, not every item on this list is something to be very worried about, but it's just some kind of a red flag that kind of should make you open your mind and think about it. Do you agree with that list? And if so, what other red flags would you say as a pediatric emergency physician I should be aware?
Yeah, I definitely agree. I think the biggest one to me is an ill appearing child, because even a lot of our other rashes, like a rash that doesn't blanch, like a vasculitis, for instance, sometimes that can be an outpatient workup. And although we want to make sure that we're not missing something more severe, the majority of those patients are going to do okay being worked up in clinic for that. And that's not necessarily the job of the emergency room to figure out the cause of a vasculitis. It's just to make sure that the patient is stable, maybe doesn't have hematuria, and that would be it. Same thing with, vesicular rashes. There's a lot of, we're seeing some chickenpox now with like decrease in vaccines, and that still is not something that needs to necessarily be admitted for. But a child who's very ill appearing, having high fever, you can have some really bad cases that I have seen be admitted for more because the child's not doing well. And so I think, to me, the biggest red flag is that ill appearing. The things that we really don't want to miss are going to be like those drug eruptions, like, TEN. That's the one thing that, is a true dermatologic emergency, and we don't want to miss it. But those kids are sick. They're in pain. They're not feeling well. That rash is spreading really, really rapidly. We're starting to see those bulla. We're starting to see the Nikolsky sign, because the skin is just literally coming off and peeling off. And that is going to be something that you wouldn't miss because that child looks so ill. Other things like, even erythema multiforme, we can have really mild cases that can be treated outpatient as well. And so I think that big ill appearing child, that's going to be the one thing that you really don't want to miss. And like, there are a couple other things. Like, I've had patients that have had erythrodermic psoriasis, kind of head to toe, pustular flares of psoriasis. And that doesn't really fit any of those things. It's just that kind of that head to toe erythema. And that can actually be a life-threatening condition because those patients become really unstable. They start to have fevers. They can't handle their temperature, and so that would be something to look for too. But once again, that's more the ill appearing rather than the rash. And so a healthy kid that comes in erythrodermic and is eating well, drinking well, no fevers, no other systemic symptoms, there's a lot of causes of erythroderma, and the majority of those probably can be handled outpatient. So I always think that the emergency room, it's more important to kind of catch those true emergencies, and anything that it can be handled outpatient that's just requiring a biopsy, better management, some blood work, that all needs to be done in the clinic setting.
Very good. If you can name a rash and an emergency, Steven Johnson always comes to mind. I've seen it several times. It's always pretty bad. The kid ends up in the PQ for a while. Can you give us, Tace, maybe 5 or 10, however many rashes that you're aware of that you don't want us pediatric emergency medicine providers to ever miss?
So yeah, definitely number one, TEN and Steven Johnson's. Those are the big ones that we absolutely don't want to miss. And seeing that mucous membrane involvement are some of those key signs. And in those, the children do look really, really ill appearing. So that would be one of the big ones I don't want to miss. Psoriasis is a funny thing in that we don't want to miss it because it oftentimes gets misdiagnosed. And I've seen patients be treated with kind of thinking it's just a dermatitis, and they are given pulse steroids or IM Kenalog. And for that, with psoriasis, when you get that big dose of steroids and then you have that withdrawal, you actually can get severe pustular flares and life-threatening flares. So it's one that we don't want to miss, in that we don't want to accidentally give the wrong medication and cause severe worsening. And so I think that that's a big important one. Another one is urticaria. And it's not that we don't want to miss urticaria, because for the most part, hives are not life-threatening and are not causing problems. But I think that they oftentimes get so misdiagnosed because it can present and look so different in so many different ways. And we call it like urticaria multiforme, where it forms those rings. If you can find true urticarial lesions, and then you see some annular lesions, we're not dealing with erythema multiforme. We're dealing with that urticaria. And that allows you to kind of be able to, rule out something that would be more concerning, such as erythema multiforme. So it's one of those where it's really, we want to make sure that we're catching it so that we can just relieve the family and tell them it's not anything to worry about. And then other ones that I think sometimes get missed is we see a lot of atopics that get secondary infections on them, and really they're fairly stable, but they can get these bad, impetigo reactions and infections on top of it. And I've even seen staph scalded skin come on top of that eczema, and that's a hard pickup because it's really hard to just notice slightly more peeling in the neck, around the face, and the axilla. But those babies are usually in really bad pain. And so whether or not they had eczema to begin with, all of a sudden coming in with like these new kind of peeling lesions and in a lot of pain, we call it like the mark of the unhappy baby, where it kind of peels around the mouth and the baby looks very, very upset, sad, crying a lot. That oftentimes is a marker of staph scalded skin. And I think that that one is sometimes missed as well, and is easily treated, just with antibiotics and sent home with reassurance. And then one other thing that we treat a lot of in our clinic are hemangiomas. And when we have hemangiomas that are growing really rapidly, they can do what's called ulceration, where they get a wound within them. And it's not that the bleeding is severe, but it just looks more like a scab within the lesion. The issue is it is incredibly painful for these babies and for the families. And so it's something that I have seen several hemangioma patients get turned away from the ER because they're told it's just a hemangioma, nothing to worry about. Yet that ulceration is something to worry about because it's a site for infection. It's a site that's going to cause scarring. And most of all, it's a site for extreme pain for the baby. And I've had to admit some of these babies with ulcerations just for pain control alone. So it's one that I consider it more of an urgency in dermatology, not a true emergency, but it definitely is something that that we don't want to miss at all.
Very good. So, yeah, no, those are really, really helpful tips for us pediatric emergency physicians. I'm going to ask you kind of along the same lines, Stacy, one more question. Again, I'm not a dermatologist, but if I recall my dermatology rotation in med school and from what I know about pediatric dermatology, it seems to me that very often, really, skin biopsy is the only test that actually gives you the answer. Unfortunately, that is not something I can do in the pediatric emergency department. What lab work or any other workup would you say would be most helpful for us pediatric emergency physicians given the limitations of what we can do? I can do a CBC, I can get inflammatory markers, etc. Among those, is there one test that you would recommend the most?
Honestly, no. I rarely order labs. And the only time I'm doing biopsies if I truly cannot tell what it is. And so the majority of my patients I diagnose clinically because I can find some sort of clinical sign. I think doing blood work in the emergency room is more just to make sure that you don't have anything else that you're missing and that the child's truly stable, that they're not dehydrated, that there's not anything more concerning like underlying infections. But from my standpoint, I don't usually use any of that and very, very rarely end up getting lab work. Because the only exception would be is if you're thinking some type of vasculitis like Enoch-Schonlein purpura or, a vasculitis in that nature, then making sure that you're getting a urine at that time.
Sure. Well, that's a good tip. Very good. So again, Tacy, thank you very much. Very, very helpful tips for us pediatric emergency physicians. And I got to tell you, I work with a lot of residents. A lot of times, especially newborns with rashes really freak out the residents because they go into the room and thinking, I better find out what this patient has. When it really is not like that, in my opinion. I just want to know if that kid is ill appearing, if there are any red flags, and if not, I send them to you guys, and you guys do a great job pinpointing the diagnosis and giving them the right treatment. Lastly, I want to ask you, Tacy, because I asked that all my guests in the show. I do my very best to honor every guest with their requests for the outro that they want to hear. Is there any band you like, song you like that you would want me to? Again, I'm not making any promises because I'm not that talented, but any outro that you would want to hear? Queen, Nirvana, Metallica, whatever it is.
Um, Gosh, you know what band I really like that I just recently started listening to some of their other songs again are the Pixies.
All right. No, so that's good. I did do Where Is My Mind by the Pixies a few months ago, but we can find another Pixies song in honor of you coming to the show.
Thank you so much.
Perfect. Thank you very much, Tacy, for coming to the show. Really, really appreciate it.
Awesome.
And that is it for today, guys. Thank you very much for listening. As always, check out PEM Rules and submit any feedback. Check out my monthly column on epmonthly.com or get in touch however you want. This is Hey by the Pixies as requested by Tacy. Thank you, Tacy, for coming on the show. Hope you enjoy the song.